and welcome back to the Deep Dive, the place where we take the world's most daunting topics and, well, give you the fast track to being the smartest person in the room.
Today, we are tackling a situation that pretty much everyone faces, yet so many of us feel completely paralyzed by it. We're talking about navigating the medical system.
Yeah.
I mean, let's be honest. Walking into a doctor's office in an English-speaking country can feel like you're stepping into a maze, a linguistic maze, a logistical one.
Totally. Especially when the person with the clipboard starts, rattling off jargon about deductibles and systolic pressure and whether your issue needs a referral. It is so intimidating. You're already not feeling great, and then suddenly you have to decode this whole new language just to explain what's wrong.
And to understand your treatment plan, not to mention figuring out what this is all going to cost you.
Right. So our mission today is, well, it's pretty simple. We want you to be able to quickly and thoroughly understand the terminology, the processes, all the implications of a standard doctor's visit.
So you can communicate with confidence, so you can feel less anxious in what is, a pretty high-stakes situation.
We've synthesized a really comprehensive guide for this deep dive. It covers everything from the very moment you check in, the logistics, the paperwork,
All the way through to diagnosis, prescription, and even that really confusing language of health insurance.
The goal here isn't just a vocabulary list.
No, not at all. It's about providing the essential context. That's what makes the difference between, confusion and being able to confidently advocate for yourself. We're aiming for real health literacy.
This is pure practical knowledge. I mean, this is the stuff that can genuinely impact your health outcomes. It's what they should have taught us in school, but, well, they didn't.
Sure.
Okay, let's unpack this. Starting with that moment, you walk through the door and face that reception desk. So you first arrive, you go up to the reception desk. And that first interaction, it kind of sets the tone for the whole visit, but it also kicks off this crucial process of documentation.
Right.
What are the key phrases and expectations we really need to be ready for right there at the desk?
Well, the receptionist's job is really to confirm who you are, what your status is, and to get that administrative flow started. So you'll hear really straightforward things like, "Good morning, do you have an appointment today?"
Okay.
Or the very common, "Please sign in and take a seat in the waiting room." Your job here is just to be concise, state your name, your date of birth, so they can verify it's you, and the time of your appointment.
So just something like, yes, I have an appointment at 10:30 with Dr. Johnson. My name is Alex Smith.
Exactly. That kind of simple clarity prevents delays right from the get-go.
Now, the source material really highlights this idea of punctuality. And not just being on time, but actually arriving early. We're told it's critical in a medical setting. Why is that? I mean, why can't I just show up right at 10:30?
That's a great question, and it points to a really fundamental difference between medical and, say, business logistics. Unlike a social meeting, medical clinics run on these super tightly managed, often interconnected schedules. And they rely on preparatory time. So arriving early, maybe 15 to 20 minutes ahead of your time, it allows for all those crucial steps that absolutely have to happen before the doctor can see you.
So that buffer time is really for the system to work, not just for me to sit and wait.
Precisely. It's for them to retrieve your file, your chart, to verify or update your insurance details, and, this is the big one, for you to fill out any necessary paperwork. Consent forms, questionnaires about your current symptoms, that kind of thing.
And what happens if you skip that buffer? If you show up late?
Well, if you're late, even by just a few minutes, you basically compress the time that's needed for those essential administrative tasks.
Right.
And that immediately reduces the amount of time the doctor can actually spend with you, which, can compromise the quality of your care.
And imagine it affects the next person, too.
It creates a ripple effect. Absolutely. If a 10-minute delay in your paperwork forces the doctor to spend 5 fewer minutes with you, that delay often carries right through to the next patient. It can cause a critical backlog. So in the medical world, punctuality isn't just seen as courtesy, it's an operational necessity. It's essential for providing care safely.
That makes so much sense. Okay, let's dive into that essential paperwork. The first big term is medical history. We all know we have one, but what specifically does the doctor need to know? How deep do we need to go?
Medical history is really a comprehensive story of your entire health journey, and it entails detailed information about any previous illnesses you've had.
Okay, like what? Chronic things?
Yes, chronic conditions like heart failure or kidney disease, but also acute things like a severe case of pneumonia you had years ago or your appendicitis. You need to list any surgeries you've had with the year and the reason, if you can remember.
Even a minor stuff.
Even seemingly minor procedures, like getting your wisdom teeth out or a tonsillectomy. And crucially, they need to know about any ongoing health conditions you're currently managing, along with the medications you take for them.
Like asthma or diabetes.
Exactly. Asthma, type 1 or type 2 diabetes, chronic pain, high cholesterol. The goal is to build a really detailed clinical profile of your body. The more specific you can be, the better. It prevents the doctor from making decisions based on incomplete information.
And right next to that on the form is usually family medical history. This one always feels like I'm supposed to remember every ailment every relative ever had. And I struggle to remember the right medical terms for what, say, my grandfather had. How much detail is actually useful? Does bad stomach problems count?
That is an excellent practical question. And while bad stomach problems is a starting point, the physician really needs more specifics to do what's called a proactive risk assessment. Doctors use this information to assess your potential health risks because so many serious conditions have a known genetic component. They'll specifically ask if close relatives, we're talking parents, siblings, grandparents, have had conditions like diabetes, significant heart disease, or certain cancers.
Like breast cancer or colon cancer?
Yes, breast, colon, ovarian. The clinical insight here is that this knowledge can actually change your care plan.
How so?
Well, let's say your father was diagnosed with colon cancer at age 50. Standard protocol might say your screening, your colonoscopy, should begin 10 years earlier than the youngest case in your family.
So I would start at 40, not the usual 45 or 50.
Exactly. Knowing this alerts the physician to screen you more aggressively or start preventive measures earlier. It helps them tailor your care plan based on your unique hereditary vulnerabilities. It turns a history lesson into a tool for future planning.
It's not just curiosity, it's a planning tool. Okay, shifting gears to maybe the single most critical piece of safety information, allergies. The source material calls this absolutely critical information. Why the extreme emphasis here?
It's a matter of patient survival. It's about immediate safety. The question, which is usually phrased as, do you have any allergies to medications, is probably the most important clinical question you'll be asked before any treatment.
And we're not talking about just a side effect, like a medicine making you a little sleepy.
No, that's a key distinction. A true allergy involves an immune system response. It can be mild, like a rash, or it can be a severe full-body reaction that we call anaphylaxis.
And that's the really dangerous one.
That is the life-threatening one. It can cause swelling of the throat, difficulty breathing, a dangerous drop in blood pressure. It requires immediate emergency intervention. So if you have a true allergy, say to penicillin or sulfa drugs, it has to be flagged prominently in your file. It's an immediate safety firewall.
That's a really powerful way to put it. So before you even see the doctor, you've established a logistics, your medical blueprint, and your safety limits. Now we get into the examination room, where the physical assessment begins with those all-important vital signs.
Right. This is where the measurable objective data comes in.
Yeah.
The nurse or medical assistant will start by taking your vital signs, or just vitals. These are the universally accepted indicators of how your body is functioning, and they provide an immediate snapshot of your health.
And those are the 4 standard ones, right? Blood pressure, heart rate, temperature, and weight.
Those are the big 4.
Yeah.
Blood pressure, heart rate or pulse, temperature, and your weight measured on the scale.
I want to zoom in on blood pressure, because this seems to be the one everyone remembers, with the cuff on the arm. We always hear 2 numbers, like 120/80. What are those 2 numbers actually telling us?
So 120/80 is the standard reference for normal, healthy blood pressure. The first number, the top number, is the systolic pressure. That represents the pressure on your artery walls when your heart contracts, when it beats and pushes blood out. It's the peak force. Think of it as the push.
And the second number, then, is the rest.
Exactly. The second number, the bottom one, is the diastolic pressure. That's the pressure that remains in the arteries when your heart rests and refills with blood between beats. It's the minimal force. And both numbers are absolutely crucial. If that diastolic, that resting pressure, is consistently high, it suggests your arteries aren't relaxing properly. There's constant strain.
Here's a clinical nuance I'm curious about. The difference between those 2 numbers is sometimes called the pulse pressure. Why does a doctor care about that gap?
That's a genuinely insightful question. It goes beyond the basics. The pulse pressure is just the mathematical difference, so 120 minus 80 is 40. If that gap gets too wide, say a 160/80 giving you a pulse pressure of 80, it can signal some significant problems, especially in older adults.
Like what?
A wide pulse pressure often indicates stiff arteries, a condition called arteriosclerosis. The arteries can't absorb the surge of blood efficiently, and that puts major strain on the whole cardiovascular system. It signals a greater long-term risk of a heart attack or a stroke. It's a key, often overlooked data point.
And knowing those numbers lets the doctor use the specific medical term. So if it's consistently high, that's hypertension. And if it's low, it's hypotension.
That's right. Hypertension or high blood pressure is a major chronic concern. It's often called a silent killer because it usually has no immediate symptoms. But over time, it forces the heart to work harder and damages the arteries.
And hypotension.
Hypotension is low blood pressure. It's usually less of a concern long-term unless it's causing symptoms like dizziness, lightheadedness, or fainting. That happens because the low pressure means not enough blood and oxygen are getting to the brain.
So the vitals are captured, the doctor comes in, and we get to the core of the visit, describing your issues. The doctor's opening crown is usually something like, "So what brings you in today?"
Or what seems to be the problem. And this is your moment. This is where you define your symptoms. A symptom is any indication of a disease or a disturbance that you, the patient, notice and report. The challenge is translating a vague feeling into concrete, descriptive language the doctor can use.
So how do we do that effectively? How do we move beyond just, "I have a headache"?
You need to specify the intensity, the duration, and the quality of the pain. Is it a tension headache, like a tight band around your head? Or is it a throbbing pain in your temples, which might suggest a migraine?
So you could say, "I've been having severe headaches that feel like a pulsing behind my left eye, and they last for 6 hours."
That is diagnostically useful. That gives the doctor something to work with.
Okay, what about stomach issues? What are the key terms there?
Well, if you feel like you might vomit, the clinical term is nauseous. So you'd say, "I've been feeling nauseous all morning."
Hmm.
If the pain is in your belly area, you'd call it abdominal pain. A more casual phrase is an upset stomach. But the doctor needs to know where in the abdomen and what kind of pain it is.
And for coughs, the source material talks about two main types.
This is vital. The distinction between a dry cough and a productive cough is central to the diagnosis. A dry cough is just irritating, it doesn't produce anything.
Right.
A productive cough is one where you're coughing up mucus, or what we call phlegm.
And does the color of that phlegm matter?
Oh, it's a huge clue. Clear or white phlegm often suggests a virus or allergies, but yellow or green phlegm often indicates the presence of white blood cells that are fighting a deeper infection. It strongly suggests a bacterial infection, like pneumonia.
What about when you're running a temperature?
That's the common phrase for having a fever, meaning your body temperature is above the normal 98.6 degrees Fahrenheit or 37 Celsius. If you feel warm but haven't measured it, you can say you're feeling feverish. A fever is actually a defense mechanism.
And sometimes you get chills with a fever.
Yes, that sensation of feeling intensely cold and shivery, even though your temperature is high. That's your body trying to generate heat, to raise its core temperature even faster. Describing fever and chills together gives the doctor a strong clue about the severity of your body's immune response.
And finally, that feeling of just being completely wiped out.
We use the term fatigue. This isn't just being tired. This is unusual, extreme tiredness that doesn't get better with rest. You might say, "I have no energy," or "I've been feeling profoundly fatigued." It's a systemic symptom that could point to something like a chronic viral infection or anemia.
Okay, we've described the problem, now we have to quantify it. The pain scale, 1 to 10, always feels so subjective. How useful is it really?
It is subjective, you're right, but it's the universal tool for standardizing pain. The doctor uses it to measure the immediate severity and, just as importantly, the change over time.
But before the number, you need the right words, right?
Yes, the adjectives. Is it a sharp pain, a dull ache, a burning sensation, a stabbing pain, or that throbbing pain we mentioned? Each of those words points the doctor in a different diagnostic direction.
And how should you use that 1 to 10 scale to really get your point across?
Well, 1 is minimal, 10 is the worst pain imaginable. The key is to think about what the pain prevents you from doing. A 3 or 4 is noticeable, but you can function. A 5 or 6 is disruptive. If you say the pain is about a 7 out of 10, you're saying it's severe enough to significantly interfere with your sleep or your work. It helps the doctor gauge how aggressive to be with treatment.
And the context of the pain is just as important as the number.
Absolutely. The doctor will always ask about contextual factors. Things like, does the pain get worse when you move? Or does anything relieve the pain, like rest or heat or ice?
And timing, too, like if it's worse in the morning.
Precisely. Pain that's worse in the morning and eases up during the day often points toward inflammatory issues like arthritis. If it's severe enough to wake you from sleep, that can be a red flag for something more serious. This level of detail makes you a reliable witness in your own diagnosis.
So now the doctor has all this information, let's move into the examination itself. How they go from listening to you to actually investigating.
Exactly. The physical examination is where the doctor uses specific tools and techniques to either confirm or rule out the ideas they formed while listening to you. It's the detective work stage.
Let's talk about the classic tools. Everyone recognizes the stethoscope. What is the doctor actually listening for when they place that on your chest or back?
So the stethoscope is for a process called auscultation, which is just listening to internal sounds. Over the heart, they're listening for the rhythm. Is it too fast, too slow, or irregular? But the main focus is often the lungs. That's why you'll hear the instruction, take a deep breath in and out.
And what are the telltale sounds they're hoping not to hear?
They're listening for clear, unobstructed air movement. Abnormal sounds are the big clues. Things like wheezing, which is a high-pitched whistling sound typical in asthma, or crackles, a rattling sound that can indicate fluid in the lungs, like from pneumonia. These sounds are powerful, immediate diagnostic tools.
Then there are the tools for looking into things more closely.
Right. The otoscope is that small device with a light they use to look in your ear, checking for infection or fluid. If you have a sore throat, they'll use a tongue depressor to hold your tongue down. And they'll ask you to say, ah, to get a clear view of your throat, looking for inflammation or redness.
And then there's the technique that involves the doctor's hands, which can feel a bit awkward but is essential. Palpation.
Yes, palpation.
Yeah.
That's the technique of applying pressure with the hands, usually on the abdomen. The doctor is feeling for things they can't see, like masses or an enlarged organ like the liver or spleen. They'll ask, does this cause any discomfort? Because the exact location of pain when they press down is a huge diagnostic clue. Sharp pain in the lower right, for example, is a classic sign that needs immediate follow-up.
So once all this information is gathered, the doctor moves to the diagnosis, the why. And as you mentioned, the most important distinction for a patient to understand is the one between bacterial and viral infections.
This is not just academic. It dictates the entire treatment plan. Bacterial infections, like strep throat, a urinary tract infection or UTI, or bacterial pneumonia, are caused by bacteria, and they must be treated with antibiotics.
And without them,
these infections can get much worse and even become severe or fatal.
and then there are the incredibly common viral infections.
Right, caused by viruses. Think of the flu, the common cold, or a stomach bug.
Mm-hmm.
And the critical insight here is that antibiotics are completely ineffective against viruses.
It's like using the wrong key for a lock.
Exactly. Prescribing them for a virus isn't just useless, it's actually harmful. It contributes to the global crisis of antibiotic resistance.
So how does a doctor know which one it is, especially if the symptoms seem similar, like a sore throat?
That's where clinical decision-making and sometimes rapid tests come in. For a sore throat, they might do a rapid strep test right there in the office. For other things, they might need lab work, like a complete blood count or CBC.
And what does that CBC show?
It can show the ratio of different types of white blood cells. High levels of one type, neutrophils, often suggest a bacterial infection. High levels of another, lymphocytes, often point to a virus. The doctor pieces all these clues together.
So if you just have a common cold, there's really no cure the doctor can give you.
Essentially, no. Your body's immune system has to fight off the virus on its own. So treatment for viral infections is all about symptom management. Rest, fluids to stay hydrated, and over-the-counter or OTC medications to manage the fever or pain. Understanding this can stop patients from demanding antibiotics that won't help.
Okay, speaking of treatment, let's talk medications and dosage. We know the difference between a prescription and an OTC medication. What are the key categories of prescribed drugs we should know?
Well, beyond antibiotics, you'll often hear about antihistamines, which are for allergic reactions. Then there are pain relievers, also called analgesics, like acetaminophen and ibuprofen. And if swelling is a big part of the problem, the doctor might prescribe an anti-inflammatory.
And the practical part, dosage. Misunderstanding the instructions is a really common mistake. What are the key phrases we need to understand?
The language has to be precise for safety. Take one tablet twice daily means one pill every 12 hours, consistently, not 2 in the morning.
Right.
If it says, as needed, you must understand the maximum you can take in a 24-hour period to avoid an accidental overdose.
And what about instructions like, take with food?
Those are crucial. Take with food means you need to eat something substantial with the pill, often to prevent stomach irritation or to help your body absorb the drug properly. The opposite before or 2 hours after a meal to maximize absorption.
And there's that one critical compliance note doctors always stress, especially with antibiotics.
Yes, you must complete the full course of antibiotics, even if you start feeling better after just a few days. Stopping early risks the infection coming back stronger. And, even worse, it means you've only killed the weakest bacteria,
Leaving the tough ones behind.
leaving the most resilient ones to survive and multiply. This is how we create drug-resistant superbugs. Taking the full prescription is a responsibility not just to yourself, but to public health.
That's a huge takeaway. Okay, we've gone from diagnosis to prescription. Let's look at what comes next. Follow-up care, deeper investigation, and prevention.
A doctor's visit is rarely a one-time thing. Good medical practice always includes planning the next steps, either to make sure you're recovering or to gather more data. And that usually starts with scheduling a follow-up appointment.
So what's the purpose of that return visit, besides just checking in to see if you feel better?
Well, the doctor will say something direct, like, "I'd like to see you again in 2 weeks," or "come back if your symptoms don't improve in 5 days." The purpose is really threefold. One, to monitor if the treatment is working. Two, to reassess your objective condition, like have your vital signs return to normal.
And the third.
For chronic conditions, it's to adjust medication dosages based on how you've responded. It's a formal check-in on the healing process.
And sometimes the first exam isn't enough, and the doctor needs to look deeper into your body's chemistry. That's when they order lab work or blood tests.
Exactly. Blood tests are like chemical spies inside your body. The most common one is the complete blood count, or CBC. This gives a comprehensive snapshot of the three main types of cells in your blood: red blood cells, white blood cells, and platelets.
And what would an abnormal finding in each of those mean?
Well, low red blood cells could signal anemia, meaning you're not carrying enough oxygen. We already talked about how white blood cells can indicate an infection, and platelets are critical for clotting, so abnormal numbers there could suggest a bleeding or clotting risk. Each one is a strong diagnostic clue.
And beyond the CBC, what are some other common blood tests people get?
Two very common preventive panels are the cholesterol panel and the blood glucose test. The cholesterol panel measures fats in your blood. You'll hear about LDL, the bad cholesterol that causes plaque, and HDL, the good cholesterol that helps remove it.
And blood glucose.
That's for diabetes screening. A persistently high blood sugar level can confirm a condition like type 2 diabetes.
So beyond blood, doctors also sometimes need to literally see inside the body. That brings us to imaging.
Right, imaging technologies let us see internal structures without surgery. The most basic is the X-ray, which is mainly for looking at bones, checking for fractures, or sometimes large masses in the lungs.
And then there are the more complex ones, like a CT scan versus an MRI. What's the difference? Why choose one over the other?
That's a key distinction. A CT scan uses X-rays from multiple angles to create cross-sectional images. It's fast, and it's great for visualizing bone, or bleeding in the brain after an injury, or solid tumors.
And the MRI.
An MRI uses powerful magnets and radio waves. It creates incredibly detailed images of soft tissues, the brain, spinal cord, ligaments, tendons. It's better for diagnosing a torn ligament or complex neurological issues, but it takes much longer.
And there's also ultrasound.
Yes, an ultrasound uses high-frequency sound waves. It's often used for internal organs or to monitor a pregnancy. Yeah. And the big advantage is that it's completely radiation-free.
Okay, that helps clarify the different tools. Let's shift gears to a broader topic, but one that's just as important: preventive care and wellness. This is the stuff you do when you're actually healthy.
Yes, preventive care is all about proactive measures aimed at preventing illness from happening in the first place, or catching it so early that treatment is simple and effective. It's a huge paradigm shift from just treating sickness to maintaining health.
And the cornerstone of preventive care is that routine visit, even when you feel fine.
That's the annual checkup, or physical examination. It's for general health monitoring. Even if you feel perfectly healthy, these checkups let the doctor spot small, often silent trends, like a slight creep up in your blood pressure, that signal future risk before it becomes a full-blown disease.
Then there are vaccinations or immunizations.
These are crucial public health tools. Vaccines stimulate your body's immune response to protect you against specific threats. We hear about the annual flu shot, the tetanus booster every 10 years, and of course the COVID-19 vaccine.
And finally, screening tests. What are these designed to do?
Screening tests are specific exams to detect diseases in people who seem healthy before they have any symptoms. Things like mammograms for breast cancer, or colonoscopies for colorectal cancer. The goal is to catch these diseases at their earliest, most curable stage.
And this section wraps up with the lifestyle advice that doctors so often give, the non-drug treatments that make a huge difference.
Indeed, they'll almost always start with diet, recommending a balanced diet. And for activity, they'll advise regular exercise, often quantifying it as at least 30 minutes of moderate activity, 5 days a week.
And moderate means getting your heart rate up, right? Not just a casual walk.
Exactly. You should be a little breathless. And these instructions are often delivered as clear commands. Quit smoking, limit alcohol consumption, reduce stress, and they always emphasize getting adequate sleep, which for most adults is 7 to 9 hours a night.
And the simplest one of all that we all forget, hydration.
Drinking enough water is essential for every single bodily function. The general advice is often about 8 glasses a day, but a doctor will stress that this needs to be adjusted based on your individual needs, your activity level, the climate you live in, your overall health.
We've covered a whole visit now, from check-in to healthy living. But what happens when the problem is too specific for a general doctor? Let's talk about the specialist referral system.
Your general practitioner, or primary care doctor, is kind of like the quarterback of your health. They can handle about 90% of health issues. But when a problem requires deep, hyper-specialized expertise, they make a referral. And what's fascinating is just the sheer breadth of medical specialization.
It's an overwhelming list. Let's break down the essential specialists we should know, starting with the heart.
That would be the cardiologist. They specialize exclusively in the heart and circulatory system. For skin, hair, and nails, you see a dermatologist. And if you have problems with your bones, joints, or ligaments, like a bad knee or severe arthritis, you need an orthopedist.
And what about all those interconnected systems in the head and neck area?
That's the ENT, which is the common abbreviation for an otolaryngologist. They treat everything related to the ear, nose, and throat. For digestive system issues, like chronic acid reflux or ulcers, that falls to the gastroenterologist.
And the really complex, invisible world of hormones.
For that, you need an endocrinologist. They manage complex hormonal and metabolic disorders, most commonly things like diabetes or complex thyroid disease.
And we absolutely have to address mental health, specifically the difference between the two main types of providers.
This is a vital distinction. A psychiatrist is a medical doctor, an MD, who specializes in mental health, and this is the key part, can prescribe medication. A psychologist or a therapist or counselor provides talk therapy and behavioral support, but they generally cannot prescribe drugs. Knowing which one you need depends heavily on whether medication will be part of your treatment.
Now let's talk about when speed is critical. When should you go to an urgent care center versus the emergency room? Because this choice has huge financial implications.
It's a very common point of confusion. An urgent care center is for less urgent, but still concerning symptoms that are definitely not life-threatening.
Like a deep cut that needs stitches or a bad case of the flu.
Exactly. Or a possible fracture or a bad ear infection when your regular doctor is closed. They're much, much cheaper and faster than the ER.
The emergency room, or ER then, is reserved strictly for immediate life-threatening symptoms.
Precisely. If you experience chest pain, sudden difficulty breathing, severe uncontrolled bleeding, a major head injury, anything that could result in death or permanent disability without rapid intervention, you go to the ER or call emergency services.
And the source material gives us that simple life-saving acronym for recognizing a stroke.
Yes, everyone should know this. It's the FAST acronym. F is for face drooping. Is one side of the face drooping when they smile?
Okay.
A is for arm weakness. Can they raise both arms? S is for speech difficulty. Is their speech slurred or confused? And T stands for time to call emergency services. If any of these appear suddenly, time is absolutely critical.
And finally, we have to talk about the financial language of healthcare. Health insurance terminology. This is often the most stressful and confusing part for everyone. We need to go into some depth here.
This financial language is loaded with jargon that determines how much you pay. Let's start with the 4 key terms everyone needs to know. First is the premium.
Right.
That's the regular amount, usually monthly, that you pay just to have insurance coverage. It's like a subscription fee.
Okay, and second.
Second is the deductible. This is the amount of money you have to pay out of pocket for your own care before your insurance company starts to pay its share. If you have a $5,000 deductible, you pay the first $5,000 of your medical bills.
Got it. So the deductible is the threshold you have to hit. Then there's the term we see every time we go for a visit, the copay.
A copay, where copayment is a fixed fee you pay for a specific service at the time you receive it, like $20 for a doctor's visit or $50 for a specialist. It's a predictable, immediate fee.
And the fourth critical term is the out-of-pocket maximum.
This is your financial safety net. It's the absolute yearly limit on your personal spending for healthcare. Once you've hit that maximum, your insurance company covers 100% of all your covered costs for the rest of the year. It caps your financial risk.
But it's even more complex than that. We also have to understand the difference between in-network and out-of-network.
This is huge. It can be the difference between a manageable bill and financial disaster. In-network providers are doctors and hospitals that have a contract with your insurance company. They've agreed to accept a lower pre-negotiated rate.
And out-of-network.
They don't have that agreement, so seeing them will cost you significantly more. Sometimes your insurance won't cover much of the bill at all. You have to always check the network status before you get care.
And this ties into the type of insurance plan you have, right? Like an HMO versus a PPO.
That distinction is everything, because it determines how you access specialists. An HMO usually has lower premiums, but you have to get a referral from your primary care doctor before you can see a specialist. They're the gatekeepers.
And a PPO.
The PPO offers more flexibility. You usually don't need a referral, and you have some coverage for out-of-network doctors, though it'll cost you more. The trade-off is that PPO plans usually have higher monthly premiums.
And I think the most frustrating parts are the administrative hurdles, things like pre-authorization.
Yes, pre-authorization means that for expensive services, like an MRI or an elective surgery, your doctor has to get permission from the insurance company before you have it done. If you skip that step, they can just refuse to pay.
And what do you do when you get that confusing document, the explanation of benefits, and it says a claim was denied?
The first thing is not to panic. A denial just means they've refused to pay, and there are common reasons, like the service wasn't medically necessary or you went out of network. If you think the denial is a mistake, the most important phrase to know is, I would like to file an appeal. Every plan has a formal appeals process.
Wow. This financial vocabulary alone, I mean, it transforms you from just a passive receiver of bills to an active manager of your own healthcare spending. It's a crucial piece of this literacy puzzle. Hashtag tag outro.
We have really completed a deep dive into medical communication today. We've gone all the way from the logistics of check-in to the definitions of vital signs to the crucial distinction between bacterial and viral infections, and right through the complex language of specialists and insurance.
The key themes we hit, symptoms, diagnosis, prescription, vital signs, allergies, and the financial side of it, they're all interconnected pieces of information that you, the patient, really have to be able to convey clearly and understand fully.
Exactly.
We started out by saying this can all feel like an alien language, but hopefully now you feel like you have a bit of a universal translator.
And the foundation of this knowledge is using it. Don't just let these terms sit passively in your brain. Try to use them. Role-play a doctor's appointment with a friend, or write out a mock medical history for yourself. Transform that passive listening into active knowledge.
If we connect this to the bigger picture, well, understanding this vocabulary gives you a sense of control. It dramatically reduces anxiety when you have to engage with this really complex and critical system. You're not just a recipient of care, you become an active partner in your own health.
That's the goal. But beyond memorizing terms, the single most important skill is just communication. It's asking questions until you fully understand. Remember those useful phrases like, could you please explain that in simpler terms?
Or, what warning signs should I watch for after I leave today?
Exactly. Never leave confused.
So your challenge for the week is to identify just one piece of vocabulary we covered today that you found the most complex. Maybe it's the difference between an HMO and a PPO, or what systolic and diastolic pressure really mean. And I want you to actively incorporate it into your conversation or just your thinking this week. Use it once. What stands out to you?
Use it, own it, apply it. Your health and your financial peace of mind are absolutely worth the effort.
Thank you so much for joining us on this essential deep dive into health literacy. Until next time, stay curious, stay informed, and most importantly, stay healthy.